panelists and chair people will be coming soon. We'll start. The first talk is by Dr. Uma Maheshwari. And the second presenter can be ready when the sir has come, Dr. Verma. So the second presenter, please be ready at the other podium so that we don't waste time. At least when the discussion starts, the second presenter should be ready at the other podium. And please stick to your time, 4 minutes with 2 minutes of discussion following each presentation. 4 plus 2, only then we can finish in time. Sir, you want to say anything before they start? It's a very tightly packed session.
It's tightly packed. I think we should start.
Good afternoon, everyone. I am Dr. Uma Maheshwari, and the title of my case report is A Milky Surprise in an Infant. I have no financial interest. Lipemia retinalis is an asymptomatic condition which was first described by Hale in 1880. It is a retinal manifestation of hypertriglyceridemia. Hypertriglyceridemia can occur as a primary familial disorder or secondary to ApoC2 deficiency, lipoprotein lipase deficiency, etc. Ophthalmoscopic features are creamy white discoloration of the retinal vessels involving the peripheral vessels in mild cases and central retinal vessels in established cases. In severe cases, the fundus takes on a salmon pink color. Coming to the grading, the grade 1, which is early, is white and creamy aspect of peripheral retinal vessels. The grade 2, that is moderate, is creamy colored vessels extending towards the optic disc. The grade 3, that is marked, is salmon colored retina with all the vessels having a milky aspect. So in our case report, we had a 6-month-old male baby that was referred from a pediatric hospital as a suspected case of a metabolic disorder for ophthalmic evaluation. He had intermittent high-grade fever, upper respiratory tract infection, and loose stools. He was born at term to non-consanguineous parents and was exclusively breastfed. There was history of premature deaths on the paternal side. General examination revealed pallor and hepatosplenomegaly. Ophthalmic evaluation showed bilateral normal anterior segments. There were no xanthelismas or eruptive xanthomas. On fundoscopy, we could see creamy white tortuous retinal vessels with lost differentiation between arteries and veins in a salmon pink background suggestive of grade 3 lipemia retinalis, as you can see in the picture. During sampling, his blood was found to be highly viscous and milky. Serum triglycerides was 2,960 milligrams per deciliter. Total cholesterol was 152 milligrams per deciliter, and HDL was 10 milligrams per deciliter. On genetic analysis, we found a mutation in LMF1 gene on exon 4, which was suggestive of combined lipase deficiency with severe hypertriglyceridemia. The child was diagnosed with lipemia retinalis secondary to familial hyperlipidemia with lipoprotein lipase deficiency and hepatic lipase deficiency. He was switched to low-fat skimmed milk and MCT oil. Phenylfibrate therapy was started. So results of lipid profile and fundoscopy findings showed marginal improvement after 2 weeks of therapy. Coming to discussion, infantile lipemia retinalis is a rare disease with very few cases reported in literature, as most reported cases were found in adults in association with hyperlipidemia. Markedly elevated triglycerides may predispose patients to develop inner retinal ischemia, central retinal artery and vein occlusions. Fundus lesions of lipemia retinalis may be resolved after appropriate treatment. I would like to conclude by saying uncontrolled hypertriglyceridemia and hypercholesterolemia, especially in neonates and infants, is highly fatal due to complications like atherosclerosis, coronary artery disease, pancreatitis, and hepatic failure. Hence, it should be detected early, and ophthalmic screening by demonstration of lipemia retinalis proves to be beneficial. These are my references. Thank you.
Excellent documentation. I have also seen 2 patients, but not of infantile lipemia, but they were in adults, and it was an incidental finding in both of my cases. I do not know whether infantile lipemia may be this thing, but in adults, which I saw 2 patients, there was an incidental finding, but TG was 7,000-8,000, very high levels, and they resolved very nicely with medical treatment. So, but I'm not very sure whether this, whatever you say is fatal, is because of existing comorbidities or because of this.
So I think it's because of the high triglycerides generally, like which can amount to any atherosclerotic plaque or any strokes.
Yeah, but I'm not sure whether to use the term as highly fatal, because that is
maybe,
what was my objection, that you use highly fatal disease. patients, it was around 7-8,000. I still remember in RPC, room number 3, I was sitting and I found, and it was shocking for me, first case, that all vessels. And we didn't grade because in both of my patients, it was all the vessels were fine. And
Just phenofibrate therapy was enough for them? Like,
I didn't start myself. I had referred it to the endocrine unit.
so
and
you do
they
not know what happened to them finally?
No, but they came back.
Okay.
They resolved.
Yeah.
They resolved, definitely resolved. Yeah. Underlying resolved. And there was no affection in the vision. There's
no affection.
Visions were normal.
Okay.
In both these patients, vision was 6-6.
Incidental
Absolutely
finding.
6-6. This was just because we saw the fundus.
Okay. So
I
what's the
don't know what
prognosis for children who are born like this? What is the usual lifespan?
Ma'am,
In the literature.
in the literature, what I've seen one article which was a 27-week-old child that has succumbed to this because of the high triglycerides. There was another case, ma'am, which was around 5 months, that also has succumbed. So gladly we could. In my case, it was not. That was not the case.
Yeah.
So
I guess we can call the next patient now.
thank you.
Next speaker, Dr. Dinesh Rao. Yeah, he is presenting a case of Stargardt's disease and incidental finding in blunt eye trauma. So the next speaker is Dr. Sindhuja Kandasamy. Dr. Sindhuja, are you here?
Good afternoon, everyone. So today's case is a presentation of Stargardt's disease, which is an incidental finding in blunt eye trauma. So, a 45-year-old Hindu female residing in Rourkela came to IOPD with chief complaint of injury left eye by blunt object. So she was apparently alright one day back and presented with diminution of vision in the left eye after injury. And she has a past history of gradual painless diminution of vision 3 years back, and she is using glasses since 3 years. There is no significant family, medical and personal history. On general examination, she was conscious, coherent, operative time, place and person, and vitals are under normal limits. On examination, right eye uncorrected visual acuity is 636 and best corrected is 618. In left eye, uncorrected is counting finger 5 meters and best corrected is counting finger 5 meters. On external examination, face is asymmetrical, head posture is erect and ocular alignment is orthophoric. Coming to right eye, slit lamp examination is under normal limits, and in left eye, she is having periorbital edema with ecchymosis and lower lid laceration of size 10 into 5 into 15 millimeters. And there is a conjunctival tear extending from 3 to 6 o'clock hour position with mild corneal edema and SELPS 2+ with traumatic mydriasis 6 mm with few iris pigments on the anterior capsule of the lens. Coming to fundus examination, she is having beetle metal appearance of in the macula, and there is halo around fovea with FR dull. In left eye, media is hazy, and she is having inferior subretinal hemorrhage with beetle metal appearance in the macula and halo around fovea with FR dull. So investigations, B scan is within normal limits. There is no evidence of vitreous or vitreous hemorrhage or retinal detachment. On OCT, there is both eyes foveal contour depressed, and autofluorescent there is hypofluorescent at back macula both eyes. So this is the ultra wide field fundus photography showing the beaten metal appearance in the right eye, and with in the left eye is showing inferior subretinal hemorrhage. This is an optical coherence tomography. There is both eyes there the foveal contour is depressed. So my diagnosis is both eyes macular dystrophy suggestive of Stargardt's disease with left eye blunt injury, and differential diagnosis are Stargardt's Best disease, pattern dystrophy, myopic degeneration, central serous chororetinopathy. Treatment. So the patient was taken to OT for lid laceration repair and local anesthesia, followed by this Predfort eye drops and moxifloxacin, cyclophase eye drops and neosporin ointment. So the first follow-up was done after 15 days, and then she was followed after a month. So the best corrected vision improved from 560 to 6/36 in the left eye. So this is the patient on the first day and post-op 30. So there is no treatment proper for Stargardt's disease now. Patient is advised to use glasses. her vision is 636 both eyes now, and she's advised to uh, vitamin A supplements are avoided as much as possible, and even in cases of eye trauma, we have to examine the patient properly, detail, to not to miss these diagnosis. Thank you.
Okay, many points here. One you said that the patient came with a history of vision loss after the injury.
Yes.
But then in your next line you said that vision was deteriorating for 3 years.
Actually, she was using glasses, ma'am, for 3 years.
Anyway, be clear in the history, that's what
Okay.
I'm trying to say. Second is, I don't know whether you can say that it is Stargardt's. You can just say that it's a macular dystrophy.
That's why I've written suggestive of Stargardt's disease.
Suggestive of.
Huh.
And what was the inheritance pattern? Was there a parents, a consanguinity? Or
Actually, she has not given a proper history, but what I am thinking was that she was having a family history of Stargardt's disease.
Okay, and then what is it that you're trying to project with this case? Because in any case, every case of injury you have to examine properly in any
Yes.
case. And
Actually,
then
we
Can
have.
you show the fundus photograph?
Ah, yes, sir.
Because the thing is that see, injury should not be, it's a Stargardt disease. That's it. Injury is just a.
That's what an incidental finding we found on the trauma case actually.
Topic is quite misleading actually. So in any case, just show the fundus. Did you do any color vision in this? Color vision.
Color
thing?
vision was normal, sir.
Normal.
Yes, sir.
Normally, color vision is.
Actually, it
affected.
has to be deteriorated, but it's normal.
And what was the refractive status?
Her best corrected.
Refractive error
She's using glasses, ma'am.
number.
Number, I don't remember.
Because you have
actually.
written as it as myopic in a
Ah.
DD. And one thing more, if fundus is visualized
Excuse me.
properly, I don't think there is a need of doing B scan in such cases if you are
I've
not
done a B
suspecting.
scan, ma'am.
It is not advised. And why
Okay.
you did the B scan? If everything is visible, you could see the fundus, the periphery, and everything.
Just to rule out other things like RD.
Why?
So it's not opening actually. Ah. Yes, this is the fundus photography.
Convincing. You see, if you have to document Stargardt's, don't take a close picture. You have to magnify this and show.
Okay.
Because this will just show there's something abnormal macula and out of focus. That's what.
Actually, I don't have a
Very,
proper
very
picture.
magnification.
We have taken it with our fundus camera. We don't have a proper imaging technique, sir. Actually.
Photograph नीचे वाला तो अच्छा ऊपर वाला is not very.
Then you're saying we should not miss such things, but what will you do by not missing or missing? You could not do anything. So you've not proven anything in this case as such.
Okay.
It's not that you prevented something or you treated something which would have caused loss of vision. So you added nothing to the treatment.
But actually, she doesn't know before that she's having the disease.
Okay,
Thank you.
Dr. Sindhuja. The next speaker is Dr. Raj. Dr. Raj Pador. Next, Dr. Vishnu Palimar. So he is speaking on management of post-traumatic choroidal hematoma. Next speaker is Dr. Siddharth Goyal. Dr. Shiva Ranjani Balraj.
First
So we have little more time for discussion because so many speakers are not there. So any audience questions for the last 2 or 3 talks? Any audience questions?
Good afternoon. I am Dr. Lohit, presenting a case of how to manage post-traumatic choroidal hematoma. A 30-year-old male came to Tertiary Hospital with chief complaint of blurring of vision in the left eye for last 2 days. He had a defective vision, was associated with pain and watering. He has trauma to the left eye with a hand of an unidentified person. There is no similar history in the past, no relevant family history. Patient was systemically stable, And ocular examination, the right eye visual acuity is 6/6 for distance and 9/6 for near. In the left eye 6/60 for distance and N36 for the near. Intraocular pressure is left eye 10 millimeters and right eye 14. On slit lamp examination, the lid and adnexia are normal in the left eye, and the cornea is clear. In antechamber, there is a streak of blood present, and pupil was irregular. Lens was transparent, and on gonioscopy, we have seen the angle relation of 1 to 2 clock hours. Fundus examination, disc and macula, disc is normal cup distribution present. There is 2 disc diameter vertical semilunar hemorrhage present. Subretinal eye adjacent scar also present. This is the anti-segment clinical photograph with we can see in the left picture with irregular shaped pupil, and in the right picture we have the streak of blood hyphema in the left eye. Fundus examination, in the left eye we can disc is normal, and there is a hemorrhage present in the around the macula area which was subretinal, and the adjacent scar is present parafoveally. In the fundus autofluorescence, it is showing the blocker fluorescence due to the hemorrhage. Fellow eye, other eye is normal with a disc and macula and healthy. On subsosity, left eye there is a abnormal foveal contour present, and with subretinal heme present with thickness of central macula thickness 212. Clinical diagnosis is right eye fellow eye, left eye post closed lobe injury with choroidal hematoma. So the plan of care we started as we thought of oral steroids and topical steroids with topical cycloplegics. If it is not relevant, we plan for anti-VEGF. In the treatment, we have oral steroids, methylprednisolone 50 mg OD after breakfast with Panta 40 mg before breakfast, and calcium tablet at the bedtime, and eye drop prednisolone 6 times a day in the left eye, tapering weekly 1 drop, and atropine 3 times a day. And the follow-up after 2 weeks, there was no improvement in the visual acuity or in the patient's symptoms also. So we planned for anti-VEGF after 2 weeks. After 1 month of the post-op of the anti-VEGF, visual acuity was noted 6/18, improved to 6/18, and near vision to N10. Subretinal blood is decreased, which was evident in fundus photo. There is still streak of blood subretinal adjacent to the scar. And subretinal also there is a parafoveal scar. There is mild streak of blood present intraretinally. So we planned another dose of anti-VEGF. After 1 month of again post-op, patient was improved to 6, 6 and 6, but parafoveal scar, it is evident in it is remained the same. On fundus photograph, we can see the left eye, now there is no heme present, but adjacent to the fovea there is scar. This is SS OCT after 2 months. We did an OCT angiography to, in case it develops any to rule out any membrane, it is normal. In the part on discussion, what the take-home message is there: if there is a blood retained around the macula area, there may be damage to the photoreceptors, maybe due to iron-related toxicity or impairment of diffusion of oxygen, and mechanical damage due to clot retraction. So treatment options always in subretinal hemorrhage, we can think of pneumatic displacement, anti-VEGF with subretinal TPA with anti-VEGF, and pneumatic displacement with obvious face down positioning. Thank you.
You think subretinal hematoma is related to VEGF levels?
No, sir. Actually, the subretinal bleed we can also we observe.
Because you gave 2 injections
Yes,
of
sir.
ranibizumab, which are anti-VEGF, and think because anti-VEGF will take care of VEGF-related disease. No?
Yes, sir.
So I think that even if you are not on anything, the result would have been same.
It will be remain same, but as I mentioned, there is it is in the subretinal area near the fovea. If there is any retraction of the clot formation or any damage to the fovea,
What will anti-VEGF do there?
it will might help in the absorption of the blood. Of course, it's
कहीं literature में लिखा हुआ है भाई there's
no,
a-
sir. There was no literature.
So I personally think the result would have been same only. You see, anti-VEGF, personally speaking, will have no role in the management of TPA is good, pneumatic displacement is very good, but these small hemorrhages due to choroidal rupture do not, I think, they overuse anti-VEGF unnecessarily. Because
Yeah,
I do not,
and
this is more of an abuse of anti-VEGF rather than.
particularly when you are saying that it is choroidal hematoma.
Yeah.
If it is even subretinal, there is something to support using anti-VEGF even in non-CNVM situations, but not choroidal hemorrhage or choroidal hematoma. Also, the second thing I would like to ask you is, did you think of pneumopexy, which may have made more sense? Again, it would not make much sense if it is sub-RPE hemorrhage versus sub-sensory retinal hemorrhage. So, what was the location of your bleed?
It is
And-
See, all the
subretinal.
points of iron toxicity or fibrin contraction are related to subretinal.
Yes,
Yes, sir.
Not
exactly.
choroid.
Exactly.
They haven't
Because
talked
they
this.
will not affect the sub-RP choroid. So those points are good, but they are for, it's an emergency actually. If the blood is subretinal, it's an emergency.
Yes.
So you have to inject gas immediately.
Yes, yes.
So-
Patient had a angle lesion also, sir.
Angle lesion.
Yes, sir. So I think of to prevent any anticipating to any glaucoma, so we can inject.
So I think the message what Mallika is trying to say is that if the
Your
blood
mic
is
is not
subretinal,
working. Your mic. Okay.
if the blood is subretinal, it's an emergency. Depending on the size of the and the location, you can do a pneumo displacement of the hemorrhage.
Yes.
But remember, these hemorrhages can occur in IPCV and other diseases also. So there, I think combined approach of both,
Anti-VEGF
pneumo
and gas.
as well as anti-VEGF and gas is required. But in
And-
this patient, actually, I would not have done anything
Yes.
except giving him some B complex or something.
Because if you say on the one hand that it is choroidal, and hence you did not do a pneumopexy or pneumatic displacement, then you cannot say that this would have caused new photoreceptor damage at all, because then the location is choroidal. So
There is subretinal blood, but there is also sir choroidal rupture. So I am saying still as choroidal hematoma. If it is there is no choroidal rupture. It is,
As long as patient is getting benefits,
Yes.
okay.
that's fine, and you are also
Yeah.
both are
So both have fared well.
Sir, is there any role of oral steroids in such cases?
Methylprednisolone, no.
No.
It's not an inflammatory phenomenon.
Yes,
It's not an
exactly.
inflammatory phenomena. It's not related to VEGF levels. You see, if you measure VEGF levels, they will not be increased in such patients. So, in any case, this is, being done. It's okay. But if you do so many such patients, believe me, a placebo or just observation will work as good. Only indication of pneumo is if the blood is right under the fovea, then you have to emergency inject gas.
at,
And if the patient comes a little late, you can inject intravitreal TPA.
Yeah.
That also helps, not subretinal only, even intravitreal.
yes, sir.
Yeah, studies have shown intravitreal TPA as well as subretinal
Yes,
work
yeah.
equally. Chal, good documentation at least. You is very good. All the modalities you have used.
So the next speaker is Dr. Sivaranjani Balraj. She will be speaking on reviewing an unusual case of ocular infiltration in leukemia. The next speaker, Dr. Disha Agrawal. Dr. Disha.
Good
Dr.
afternoon,
Vinita
everyone.
Are these people to be graded?
Dr.
Or?
Vinita.
No.
Dr. Ranjita. Dr. Pooja.
Good afternoon, everyone. I'm going to be reviewing an unusual case of ocular infiltration in leukemia. So, a 14-year-old boy presented with complaints of severe retroorbital pain in both the eyes, with accompanying diminution of vision since about a week. He had no other significant complaints. His clinical findings: his best corrected visual acuity in the right eye was counting fingers close to face, and in the left eye was 3/60. Ocular adnexa were within normal limits. Extraocular movements were full and free in all the directions of gaze. His anterior segment was normal. Coming to his fundus, both of his eyes showed diffuse subretinal infiltrates with vitreous cellular infiltrates, vitreous seeding, and exudative retinal detachment. There were multiple thrombi in the blood vessels. So at this point, his father reveals that the child has had a cessation of chemotherapy around 4 months ago. This is how is his right eye, and this is how his left eye appears. As you can see, there are multiple thrombi occluding all the blood vessels. There are vitreous infiltrates and subretinal infiltrates as well, and there is an exudative retinal detachment. So on the basis of clinical findings, we made a diagnosis of bilateral leukemic infiltration with vitreous seeding. The child was promptly referred to an oncologist to further start on his treatment. So the disease synopsis was the child was found to have had a relapse of high-risk acute lymphoblastic leukemia. His cytogenetic studies showed he was a BCR-ABL1 positive along with TCF3 PBX1 translocation. He was advised reinduction of chemotherapy and was started on triple intrathecal therapy, which consisted of methotrexate, cyclophosphamide, and vincristine. Coming to my discussion, leukemias are a group of neoplastic disorders caused due to the malignant transformation of hematopoietic stem cells. The ocular manifestations are considerably rare, and they may either present after the diagnosis or after the diagnosis has been established or as a sign of relapse. It could be primary due to the direct invasion of the malignant cells, secondary from the dysplastic cells, chemotherapy, or it could be secondary to the hematological changes like anemia, thrombocytopenia, and the hypercoagulable states. The relapse of a hematological malignant disorder presenting predominantly with ocular complaints is rare. The optic nerve is known to be an area of the disease relapse site, being a pharmacological sanctuary, and it is relatively unaffected by systemic chemotherapy. So the primary ocular involvement can have infiltration of the anterior segment, vitreous, choroid, and the retina, having uveitis, choroiditis, and retinitis kind of pictures. There could be infiltration of the optic nerve with or without cranial nerve palsies, and orbital infiltration mimicking inflammatory conditions. This patient then followed up after 3 months, during which he underwent chemotherapy and an arduous stay at the intensive care unit. He was symptomatically better during his follow-up, and his best corrected visual acuity in the right eye was still counting fingers close to face, and the left eye, it improved to 6/60. His left eye showed a bit of neovascularization around the disc and some amount of reduction in the subretinal infiltrates, but he still had exudative detachment present. These are the post chemo induction pictures. So to conclude, with the advancements in diagnostics and medical therapeutics, the survival of patients with acute leukemia has considerably increased. But it is still difficult to appreciate leukemic involvement of the eyes, more so in the pediatric age group, as they remain asymptomatic, and also due to the inability of the child to convey his or her symptoms. So prompt recognition of the varied ocular presentations is important in assessing the course and prognosis of the disease. We should, as ophthalmologists, we should be going hand in hand with the hematologists and the oncologists to take over the treatments. I still believe there is a void in the treatment modality for intraocular or orbital involvement in leukemia, and comparatively, acute lymphoblastic leukemia has an event-free survival rate, a 9-year event-free survival rate of approximately 61 plus or minus 4%. So it has a relatively better prognosis when comparing to acute myeloid leukemia. So it becomes imperative to improve the functional quality of the patient also. These are my references. Thank you.
Very nice presentation actually. It's a obvious case. This was a patient who had a known disease, but sometimes ophthalmologists may pick up for the first time also. You see, I remember picking up at least one patient where we referred and the patient was diagnosed to have leukemia. But this is really wonderful that documentation pre and post you should show together also.
Okay,
At least in the left eye there was a very good improvement. So manifestations could be directly because of the leukemic cells or infiltration, or because of associated hematological like these patients may have anemia, thrombocytopenia. Because my patient, what I'm talking, he had a lot of white-centered hemorrhages. So we suspected something. We didn't suspect leukemia. We just referred for hematological evaluation. It turned out to be leukemia. So very nice presentation, and ophthalmologist's role is definitely there in guiding also whether this patient requires treatment or remission or whatever. And your patient was on 3 drugs.
Yes, sir.
Actually, most of the time, I think if this is not a known diagnosis, it is missed from the ophthalmologist side. So we have to be more careful. If we see retinal vein occlusion in a young person, most of the time we will try to think it's inflammatory, but we might burn our hands. Or if you see a bilateral papilledema, we would assume it is BIH, benign intracranial hypertension. But if you do a hemogram, you can pick up leukemia causing bilateral papilledema. So we actually lost a patient, lost life. She was diagnosed as IIH. After she came to us, it was bilateral severe papilledema. Later on, CBP showed that it was leukemia, and she expired. So it's possible, it's known actually. So we have to be.
So the message is, if in a young,
Yes.
you have this manifestation of vascular events
Yes.
in the retina, which may include disc edema, which may
Yes.
include vascular blocks, venous blocks. This patient should definitely be referred for hematological evaluation.
Yes. And another way it can present it as endogenous endophthalmitis in a young person who's otherwise healthy. So we had a young boy, 8-year-old, who came with a abscess, retinal abscess, and turned out that he was immunosuppressed because of his leukemia. So endogenous endo in a young child or a young person who's otherwise healthy, again look for immunosuppression caused by these things. And prognosis for life, if they have an ophthalmic manifestation, generally these patients we lose. I have yet to see a patient we diagnosed and the patient was not finally lost. Lifespan is affected generally. And one of the, if you have any doubts about the appearance that you are getting, we had a serous detachment in a young girl, 14-year-old. So we did an angiogram because we couldn't understand and the diagnosis was not known to us. When we did an angiogram, we saw starry sky appearance, lots of starry kind of appearance. Then I read up on the internet and that was classical of leukemia. And she had been admitted because she had multiple infections. So they were not able to make out what was the cause. So we made the diagnosis. So you have to be, your index of suspicion has to be very high.
Thank you. Very nice documentation. Next is.
Next presenter is Dr. Pooja Bang. She is presenting on the visual disability of FEVR versus the fever of getting a good C.
So all these 3-4 are absent.
Yes, 6 and 1. Next speaker, Dr. Hema.
We are already reaching the end of the session. So we would really like if the audience could have a lot of questions on these topics.
Can I have a slightly longer discussion because I have a few points which I was going to cut short, so I can do that. Thank you. Good afternoon, everyone. So here is a cornea specialist talking about community ophthalmology and to the retina specialists. And so I don't know what I'm going to say, but I'm going to tell you all a story. And the story is about you. So you have met a 13-year-old child 6 years ago and diagnosed him with familial exudative vitreoretinopathy. He had to undergo a surgery in the left eye, laser in both eyes, and 2 years ago he came back. You all had to do another repeat surgery in the left eye, a retinal surgery, and also a cataract surgery was done. However, the left eye was lost, and in your heart you all are praying that with all your effort, the child grows up with a minimum disability and he does something in life, something worth a career. So he's 19 today and he comes to our disability board and he has given his NEET exam for his MBBS. So we have a verification board, disability verification board, wherein we certify the amount of disability. So he has come to us and we are evaluating him. So we specifically asked for any premature birth or NICU stay, and that was not there. No oxygen therapy was given, based on which we got this history, and there was no systemic association of any kind. General examination was normal. This was his vision. Left eye, as I said, we found that there was band-shaped keratopathy, 2 PBIs were done, there was an occlusio pupillae, and there was no vision, counting fingers close to face. In the right eye, he was correcting to 612 from 618, and he was a high myope. Both the eyes were slightly smaller, the corneal diameters were slightly smaller, the pupils were a little sluggish in the right eye, and small lens opacity superiorly. So this is what the right eye looked like. And in the fundus, we saw all the traction and the sheath of vessels and the slightly hypoplastic disc and a deviated fovea, an inferiorly displaced fovea. And in the periphery, we saw this, and this was the left eye where there was no glow. No fundus picture could be seen. So we did an OCT, and again, there was some inferior RNFL loss, nasal thinning. There was a pull, and as you can see, there's a slight stretching of the retina and a pull up of the retina there. And the foveal dip luckily was normal. So we pulled out our charts.
Now, according to the visual acuity, he has 6/18 best corrected in the right eye and hand movements close to face in the left eye, which amounts to 30%. Now, the biggest if is that in order to get into MBBS, he has struggled, he has given his NEET exam, but he's a disabled child. You need to have to get into the PWD quota between 40 to 80%. So anything under 40, you're not eligible for PWD. Anything above 80, you're not eligible for MBBS. So, and if you're between 40 and 80, you have to be brought to below 40 by low vision aids in order to be eligible to actually pursue the course. So the criteria is 40 to 80, the magic figures. But he was somewhere below 40, he was in 30 range. Sorry, this star has got shifted. So the score was, he has a disability, but as of now, his career doesn't look very bright. So we were a little sad, upset for him. This is the first time we are trying to see, because y'all have put in that effort, y'all have done those surgeries, y'all have made that effort, he has made the effort, he's given the exam, and for the first time, it's always that we are trying to reduce the percentage because they're always exaggerating, they're malingering, lot of malingerers coming to the disability OPD. And this for the first time we say that if such a patient can get 30%, a one-eyed person with an absolutely normal other eye, then why should this person also get 30%? If this can get 30%, then even this, is he going to get 30% and we're going to just say, okay, sorry, we are not going to give you? So what we did is, we thought of the other criteria, and that was the visual field criteria. We did a 30-2. Now, what we couldn't understand, in this visual criteria, let me tell you, that the worse eye, the better eye has to have a field of less than 40 degrees at the center, the better eye. So here, we could understand whether we should take this central as a field or this as a field. So if we would take this, then he would come to 100%. So he is not in the 40 to 80 criteria. And if we take this, then he is better than 40%, so he is not in the visual field criteria only. So what do we do? Again, his score not helping. We were really wanting to help this patient. How do we get him a PWD criteria without any, any cheating on our part, okay? So what we thought was, okay, let's repeat this field, but we tried to use our brains and then we did a blue on yellow. We have never known, or it has not been documented that a blue on yellow can be used in such cases, but we thought, okay, let us see, because these are relative scotomas. So let us see if these become absolute on blue on yellow, and yes, they did. They did. So these are the fields on white perimetry, and these are the fields on blue on yellow. So now we could get the 99 percentile, and this was the 24-2. If we had counted this, he was coming to between 20 and 40, which was what we wanted, which was 60% disability, because the other eye was 0. And if we had used this central part, he would have come to 80%. So we got him right in the middle of 40 to 80. Again, this was a win for us. Disability, and one by one, the score was 1 by 1. But the challenge is now to get it down to less than 40, to make him eligible for MBBS. And so we thought, okay, if the fields are problematic, we have to use a field expander. So, sorry.
Doctor, can you
So
wind
we
it
used
up?
a field expander, and this is
Can
what
you
we
wind
got.
it up?
This is the last 2 slides. We used a field expander, and with the field expander, he came to more than 40 degrees field, so 30% disability. So finally his percentage was 60, correcting to 30. So finally, I think we won it. Y'all won it. His rank improved from 9 lakhs to 2,500. And I'm sure he's going to walk into one of our colleges and own that stethoscope. It's because of you. Thank you. And I just wrote, for my child, Exactly 10 years ago on this day, I was not delivering a lecture but a child. And my score was on that day, the sun, one is one, one and a one. So thank you so much. This is just the discussion as to why we called it FEVR. These are other pictures of. Thank you.
Anything that scientific that you want to
Actually,
talk about?
I am confused because the presentation it became more of an emotional talk rather than.
Sir, I didn't know what to say as a cornea specialist to a retina specialist, and I know this is what you all always must be thinking. What will the child land up with?
We are all here to help these unfortunate, occurrences in life. But believe me, wheresoever I have tried to help, ultimately we have been caught. Because
No,
you
so,
see, when the guidelines are established,
So we
by
wanted
a
to go as per
department,
guidelines, and there was
Yeah.
nothing about relative scotomas at all. We tried to read up, and there was nothing at all.
Yeah.
So and there are so many gaps in the disability. There's just
There
two
are,
pages,
there's no
and we have
doubt.
to read between lines. And there are a lot of recommendations being given by the earlier people, and we are trying to write up a few more
But
recommendations for the government.
believe me, Pooja, whatever you have done for this child, whether he comes with stethoscope or not, let's say, other thing, wherever he will be employed or wherever he will go, they will do a retest. And they will ultimately, because they will not have all this brain behind that, how to, do test 20-2 or other field, they will develop.
So no, sir. So all
They will
these
not,
okay.
because
So all these places, children, they come with a existing
I know.
UDID certificate,
I'm
and we
not trying
just
to defend, I'm
they
not
are
trying to
already
say.
40%. He came with
Yeah.
40%, and
Okay, anything that you want to talk about the disease itself, because people here are more interested
in the
disease.
retina.
Fever.
Yeah. Is there anything you want to say, or anybody has any query about this FEVR?
So what really clinched it for us was that there was no history of prematurity or oxygen use, and there were those folds and sheaths and displacement.
Okay, can we go to the next talk then? Drug-induced transient myopia.
Thank you.
Dr. Deva?
You have done a good effort.
Yeah, please come. I think one more speaker has come now. Yes.
Good afternoon, everybody. I am presenting a case of drug-induced transient myopia. A 17-year-old female patient. She presented to the OPD with complaints of acute onset of headache with bilateral eye pain since one day. She had associated history of blurring of vision in both eyes for one day. There was no history of redness or watching of eyes or no history of any ocular trauma. The patient had history of migraine for which she was taking treatment from outside. She had no history of any chronic illness or any chronic medication. There was no history of any previous spectacle use or any other form of ocular treatment. On examination, she was conscious, oriented to time, place, and person. The vitals were within normal limits. Afebrile, no pallor, ictus, cyanosis, clubbing, lymphadenopathy, and edema. Ocular examination, the head posture was erect, facial symmetry was symmetrical, ocular position was orthophoric, and extraocular movements were free and full in range. Refraction, both eyes showed visual acuity of 5/60 with improvement in pinhole to 618. AR showed -4 spherical in right eye with 0.75 cylindrical, and left eye shows -3.5 spherical and -1 cylindrical lens. On subjective correction, the vision improved to 6.9 with -4 spherical in right eye and improved to 6.12 with -3.5 spherical in left eye. Color vision in both eyes were found to be normal. On measuring intraocular pressure using non-contact tonometry, right eye showed 58 millimeters of mercury while left eye showed 59. With applanation tonometry, the corrected IOP was 48 in right eye and 28 in left eye. Gonioscopy was done which showed closed angles in all 4 quadrants in both eyes. So the anterior segment examination showed anterior chamber was shallow in both eyes with ill-sustained reacting pupil in both the eyes. Undilated fundus examination was done which showed normal fundus findings. So the anterior segment OCT was done which showed a ciliary body effusion with acute angle closure in both the eyes. But the raised IOP and the closed angle findings in gonioscopy, a provisional diagnosis of acute angle closure glaucoma was made. In view of the young age of the patient, detailed medical history was taken, and the patient was found to be on oral sumatriptan for migraine for past 1 week. Due to the atypical presentation, neurologist's opinion was sought for headache, and as per their advice, MRI brain and orbit was done, which was found to be normal. So the patient was treated as a case of acute angle closure with anti-glaucoma medications, which included IV mannitol, topical pilocarpine, temolol, and sumatriptan was stopped. Patient symptomatically improved post-medication, with the IOP in both eyes being 23 and 28 millimeters of mercury respectively the next day. The patient was discharged after 3 days with topical timolol. At the time of discharge, both the anterior segment was normal with no pain and normal IOP. The patient came for review visit after 5 days. On examination, both the visual acuity was found to be 6/6, with the IOP being 13 in right eye and 14 in left eye respectively. The AR reading and diffraction were found to be within normal limits. Both the anterior segment was within normal limits, and the gonioscopy showed open angles in both eyes. So based on the clinical findings, medical history and response to treatment, the clinical diagnosis of drug-induced transient myopia was made. Several case reports of transient drug-induced myopia have been found to be associated with secondary angle closure glaucoma. Caimbo stated in a study that these drugs were known to produce effect included mainly sulfur drugs and drugs like astazolamide, indapamide, sulfasalazine, methazolamide, cotrimoxazole, selective serotonin reuptake agonists, and psychotropic agents. The possible mechanism is thought to be an allergic reaction to drug causing ciliary muscle contraction and edema. So, Chengru Su in his study, he said that sumatriptan was the cause of acute angle closure with the mechanism that binding of serotonin receptors found in the iris ciliary body complex. It increased the production of aqueous humor and induced an increase in IOP. Wiskinski stated in his study that the combination of the above mentioned drugs may lead to an increased risk of iridocorneal angle closure and may further exacerbate the other mechanisms. So these drugs were found to induce refractive changes of the eye by either one of the following 3 mechanisms, which included spasm of the ciliary muscle causing increased refractivity of the lens, increased refractive power of the lens contents due to water imbibition, and swelling of the ciliary processes causing forward placement of the lens. So increased refractive power of the lens is sustained accommodation induced myopia. Discontinuation of these medication led to complete resolution of anatomical shift with ocular myopic changes clearing up completely. Ciliochoroidal effusion, transient myopia resolved, and rapid resolution of the angle closure occurs after discontinuation of the drug. If the intraocular pressure remains uncontrolled, additional therapies such as topical intraocular pressure lowering medications may need to be considered. So our case report here highlights the importance of timely diagnosis and appropriate treatment for drug-induced bilateral acute angle closure. So clinical physicians should be cautious about this potential side effect of sumatriptan and other sulfur drugs and should be attentive to development of blurring of vision or eye pain following initiation of the therapy. So with this case report, we highlight the importance of knowing the property of the above mentioned drugs in causing acute angle closure and transient myopia in young patients. These are my references.
Very well documented. I think this highlights just the importance of history taking, drug-induced history taking. One of the epilepsy drugs, I think, that is topiramate.
Topiramate, yeah. That is the most common actually. I was going to say that.
We have seen a couple of cases where it induces narrowing, and people have done even YAG PI for all these patients. But nevertheless, history was not taken. But later on, we found out that that was a long time back. That patient presented with ACG in both the eyes, and you are right, it causes ciliary body effusion. But sometimes I think lens also has been blamed. It causes some lens swelling also.
Imbibition of
So did you measure lens
yes,
thickness also? That was not.
Was not.
But so very well documented. But you see, you are right. All the sulfur drugs, including Diamox and acetazolamide, they also have been implicated in this drug-induced myopia.
In fact, any patient who has sudden onset of refractive error or vision drop should have a neurological, we should ask a neurological history for migraine. This topiramate and the other drug which you mentioned, they are all anti-migraine medicines.
Yes.
Plus, Diamox can paradoxically cause raised IOP. Given for lowering the IOP, sometimes it can paradoxically increase the IOP by this mechanism. So we have to be alert if the patient's IOP has gone very high after starting Diamox, we should immediately stop it.
Okay.
We've had one patient like that at least.
Diamox also causes a similar mechanism.
Yes,
Sulfur drug,
yes.
a similar mechanism of ciliary body effusion.
Some other drugs like chlorthalidone and some Diuretics can also cause it. But
Excellent.
topiramate especially, topiramate, if you hear that word, you should be immediately alert that a lot of ocular problems can
That is
happen with
used in
topiramate.
epilepsy, no?
Migraine, mostly migraine.
Our patient was, epileptic.
Okay. Yeah,
He was
any neuro problems mostly.
Yeah. But wonderfully documented. Very good.
Thank you.
Is that over?
No, one more.
Dr. Ranjita, she is speaking on a rare case of 8 years old child with persistent hyperplastic primary vitreous.
PHP.
Any other speaker?
Chairman ARC, Prashant, we are waiting for you. Come.
Best of all, sir. We are in meetings.
Acha. I just saw you.
Just a moment. So I have 10 more minutes.
Good afternoon, everyone. Myself, Dr. Ranjita Amanatya. I'm first year PG resident. I'm going to present a case about a rare case of a 8 years old girl child with persistent hypoplastic primary vitreous, that is PHPV. The patient name was Lagna Rana, age 8 years, sex was Hindu female child, address was Atavira, Bargarh, Odisha. She came with a chief complaint of diminution of vision and white spot in the right eye since birth. The history of present illness, to start with, the 8 years old girl child presented with her father to the IOPD with complaint of the diminution of vision and white spot in her right eye since birth, which was painless, not associated with watering, redness, discharge or floaters. Coming to the history of past illness, there was she was not a known case of thyroid disease or sickle cell disease. Why I'm talking about sickle cell disease? Because it is mostly seen in the western Odisha, and no history of ocular trauma or head injury was there. No history of any ocular surgery or the laser treatment were there. Then no history of allergies, no history of antenatal or the perinatal complications was there in the mother, and the mother serology was negative. The family history, no known ocular disease was there in the family history. Coming to personal history, the patient had normal body build, normal bowel and bladder habit, and the patient was on a mixed Indian diet. In general examination, the patient was conscious, well oriented to time, place and person. No pallor, icterus, clubbing, koilonychia and lymphadenopathy and edema was there. BP was 100 by 72 millimeter mercury, and pulse rate was 92 beats per minute. And the systemic examination, the chest was bilaterally symmetrical and BVS was heard. CBS S1 and S2 was there. CNS, there was no abnormality seen. Coming to the ocular examination, her visual acuity in the right eye was PL positive, that is the perception of light was positive, and the PR was inaccurate. And in the left eye, it was 6 by 6, and the IOP was 14 in the right eye and the 12 in left eye. Extraocular muscle was bilateral and full in all direction in both eyes. And coming to the AR, it was no target in the right eye. Anterior segment examination showed in the right eye it was microphthalmos was seen in the eyelid, and the eyelashes there was no abnormality seen. Conjunctiva it was quiet, cornea was clear, AC was normal, iris was normal, pupil pupil was circular and LR positive, which was sluggish also, and leukocoria was there. Lens was cataractous. Coming to the left eye, it was normal. On the slit lamp examination, there was a cataractous lens present and leukocoria was there. In the posterior segment examination, the mydriasis was mid-dilated. It was mid-dilated in the right eye, and ocular media was hazy because of the cataractous lens, and the rest couldn't be assessed due to the hazy media, that is the optic disc, macula, blood vessel, periphery and general fundus couldn't be assessed. And in the left eye, it was normal. And coming to the ultrasound B-scan findings, we found a wide echogenic band extending from the back of the lens to the front of the optic disc in the right vitreous cavity. as we can see in the second and third picture, thin band is connected to from the optic disc to the anterior posterior capsule of the lens. In the investigation, the blood and urine examination was within normal limit. Viral markers was non-reactive. Ultrasound B scan shows the persistent hyalid remnants, and the MRI orbit showed the triangular retrolental tissue. Treatment plan was to do the surgery due to the abnormal lens morphology and advanced stage of the PHPV. Vitrectomy with lensectomy and capsulotomy under the general anesthesia was planned to remove the fibrovascular tissue and cataractous lens. But unfortunately, she was rejected for the general anesthesia owing to the cardiomegaly. So my provisional diagnosis was mixed PHPV with cataractous lens in the right eye. Thank you.
Why did you do blood and urine test and all these things here? So those are not warranted. In any case, the USG picture, I did not find it very convincing for the hyalid remnants. Can you show or blow up that picture? It is a clear-cut, PHPV means small eye with prominent ciliary processes and some lens abnormalities. And generally the visual prognosis, even if you do lensectomy and you see these patients sometimes may, if depending on the vascularity of that Clockett's canal, they may not bleed. Prognosis is generally not very good because of the associated microphthalmic eye and as well as the retinal changes also. Yeah. So surgery is not very rewarding. They may, because if the other eye is normal and if this eye is showing all these abnormalities, surgery should be done with very guarded prognosis.
Sir, as the PSPV is mostly unilateral,
Yeah.
so we might think to be the.
I know surgery, what I'm saying is visual results are not very rewarding.
That is why, because it is unilateral and you have a good eye, it makes no sense to struggle with this. If both are blind, you might try because okay, you want to try something. But when one eye is good, that's what you choose.
See, the reason is whenever patient is taken for surgery, the hope and aspirations increase. The parents, they start hoping that patient will have good vision. So if patient is with you, then it's okay. You can go ahead and do it.
Yeah, see, there were many things which anonymity of the patient, so you should not give the name so clearly. It was not required. Then you said microphthalmos. In the eyelid examination, you said microphthalmos. But that's not part of eye. Microphthalmos is not part of eyelid. So that was the thing. What is LR positive pupil?
LR light reaction was there.
So that is your own made. You have made it on your own LR. So you should write pupil was sluggish. And rejected for GA. The correct word is not fit for general anesthesia. Not rejected.
Okay.
These are the only things. Just for the benefit of all students, I thought I'll make out these points. The case is good.
So I think with this we can conclude this session.
Yeah, if anybody has any queries about any of the topics discussed, we have 15 minutes. No, more than 15 actually. 15 only? Okay. Anybody has any queries, anything?
Only suggestion to the chairpersons of the scientific committees that to make it more attractive, we should have some test case of the session. That will make it further, lucrative to attend some sessions.
And also some penalty for those who don't come now, because a lot of presenters are not there, so we are wasting time.
So that I think we should, as chair moderators of this session, we should give this recommendation that 1, 2, 3, 4, 5 people have not come.
That causes a lot of waste of time. A lot of other people are waiting to present who may not have got the opportunity.
And I agree with you, Malika, this should be taken seriously because our body of more than 26,000 people, there are so many people waiting to give presentation.
Exactly.
And if these 5 people have been accepted and not coming, they should be taken seriously. No, Vivek?
Yes, absolutely.
But I am telling you, Vivek, when I was chair of scientific committee, we used to put a blacklist on that and no podium presence in next AIOs. And that was implemented. And we will also put in AIS times in a box that these people have sent you. Aim was not to, aim was that because we have so many other people in the queue. So in any case, we wind up this session.
Yes,
Have a
I think
cup
if
of tea.
nobody has any queries at all, Dr. Prashant, anything to add?
Sorry, I came late.
Okay. So then I think we'll wind up. Thank you, sir. Thank you, Prashant. Thanks for. Bye. Thank you, everyone.